Good morning, everyone. Welcome to our first discipline group session for the nutrition track. And thank you all for being here bright and early. I see that people are still filtering in and getting some food. Please continue to do that. I just wanted to give a brief welcome and start off by introducing myself. My name is Juliana Bailey, and I'm the chair of the nutrition group for the NACFC program committee meeting. And I would also like to acknowledge our other program planning committee members. We have two of them down here in front. Terry Schindler. Terry, if you want to stand. And Kay Vabrina. We also have Gretchen Garlow, who I don't know if Gretchen's made it in yet, and Kimberly Altman. And just a big round of applause for everybody who's worked very hard on organizing 3 days of programming for our discipline. And then I also just wanted to encourage everyone to please write down all of the wonderful ideas that you get along the way as you attend the sessions. We'll be sending out a survey requesting that you send in your ideas both for session topics next year and speakers. And please feel free to reach out to myself or Terry or Kay or Kim or Gretchen if you see us and want to pitch an idea verbally. And thank you all for being here. Without further ado, I'm going to turn it over to our wonderful moderators.
Thank you. Hey, thank you, Julianne. I just want a little kind of reminder because this room's gonna be really packed. So if your backpack is not needed to save a seat for someone else, please put it on the floor. We'll put it in the back so someone can sit every seat that all possible to squeeze in. Try not to open another overflow if we don't have to. So if you can kindly put your backpack on the floor, so we can have everybody get the seats. There's a plenty sun over here. Try to kind of squeeze in as much as possible. We got lots to cover. Okay. Thank you all for being here. My name is Audrey Snell. I'm one of the dietitians at the Billings Clinic in Montana. Today's our topic is metabolic health and cardio risk. So if you by accidentally come to the wrong room, but if you do come here to the right place, welcome you. So there's no disclaimers in here. A few housekeeping, since this is early in the morning, just FYI, will be recorded and uploaded to the YouTube. So please silence all devices because I'm sure we have a long set for this morning to get up in here. And then reserve all the Q&A questions until later at the end of the sections. And there's actually only 2 mics on the floor. If you're welcome to come up to the mics, that would be great. If not, you can submit it to the mobile app. This is our subject, objective today is to illustrate the metabolic changes in the era of a highly effective modular with the GLP-1 update and discuss cardiovascular disease risk and hypertension in CF. And last, we'll wrap it up with review nutrition considerations for aging-related disease in CF. Here's our wonderful speakers up on the podiums. We do miss Lindsay Papas. Unfortunately, she couldn't come in today. And then we have Jessica. She's wonderful step up for us today. So I'm going to welcome Dr. Levine first. And while she get herself up in here, I will give a little introduction for her. Yes, just give me a second. I'll get her things ported up. Okay. Dr. Levine is a professor of medicine at Washington University School of Medicine in St. Louis, Missouri. She is an endocrinologist with an interest with cystic fibrosis-related diabetes, post-transplant diabetes, diabetes control in pregnancy, nutrition, overweight management, and both bone health in patients with CF. Dr. Levine has also done work looking at involving nutritional needs in patients with CF in the era of highly effective modulator therapy and has participated in the creations of a post-transplant patients' care guidelines, which also address the endocrine aspects of care for patients with CF post-transplant, lung transplant. So let's welcome her presentation on dysglycemia in the era of him.
I just wanted to clarify as Dr. Littman gets to the stage, if you have questions, if you go into the app, if you click on our session, there's a little spot at the bottom that has Q&A, and so you can put questions in there too, and we'll hold all questions until the end.
Good morning. Thank you for inviting me. Thank you for being here. I know it's really early. So we will talk today about cystic fibrosis-related diabetes, type 2 diabetes phenotype, and how these are emerging and evolving in the era of highly effective modulator therapy. So I would like to review the pathophysiology of both of these diabetes types. There is, as you know, some overlap. Talk about how highly effective modulator therapy affects glycemic control, and then describe this emerging phenotype of insulin resistance and how we decide how we want to approach diabetes treatment in patients with cystic fibrosis-related diabetes or diabetes that shows more features of type 2 diabetes. So as we know, cystic fibrosis-related diabetes can affect up to half of adults with cystic fibrosis, especially if we focus in on our patients with more severe mutations, such as delta F508. Some of the risk factors that increase someone's probability of developing diabetes include age. Now that we have an aging population, we will see more diabetes. Severe mutations, as I had mentioned, partially because those are also associated with pancreatic insufficiency. Pancreatic exocrine insufficiency does create an unfavorable environment for the beta cells and the alpha cells too, and predisposes to diabetes or increases the risk of diabetes. Glucocorticoid exposure, which our patients do get steroids from time to time, although less now in the context of effective modulator therapy. For folks who are undernourished and who require supplemental nutrition through tube feeds, they do become hyperglycemic because of the kind of bypassing the incretin effects as well as increased inflammation. And then family history of type 2 diabetes and some multigenetic influences on that. A lot of that work has been done by Dr. Blackman at Hopkins. And when we think about cystic fibrosis-related diabetes, we know it combines features of both type 1 diabetes in a sense of insulin deficiency, but also type 2 diabetes in terms of insulin resistance. So this graph, if you look at the line over on the right side of the graph and you look at the blue line, this is to show that diabetes increases in incidence as the patient ages. We haven't had as many data for people in their 60s or 70s, but we'll definitely see that emerge. So this is just to illustrate that diabetes increases in incidence with age. So in terms of pathophysiology, it is extremely complex, and there are multiple factors that lead to diabetes in patients with cystic fibrosis. So we have the defective CFTR gene. We have these viscous secretions that lead to exocrine pancreatic dysfunction. We create an inflammatory, unfavorable environment for the beta and alpha cells to function properly. And to date, most of our patients who have diabetes and CF already have pancreatic insufficiency. I think that as we see patients start modulators earlier and as we see more overnutrition, we will probably see patients develop diabetes, more of a type 2 phenotype, without developing pancreatic exocrine insufficiency, but that is my prediction. So with pancreatic insufficiency, we have fat malabsorption, malnutrition, which creates insulin resistance. Inflammation also contributes to insulin resistance, steroid use, as we discussed, and then that leads to decreased beta cell function and insulin deficiency. So possibly the CFTR itself is contributing to what develops into cystic fibrosis-related diabetes. It has been proposed that the CFTR in the beta cell is needed to lead to the changes in the cell that take place with calcium influx that lead to release of preformed insulin granules. So when we eat, we should be able to have some insulin that we can release immediately from our stores, from the preformed vesicles, so we could have that peak in our insulin secretion, so we do not peak in our glucose. And then we have some insulin release that occurs after that. It is hypothesized that one of the mechanisms with the CFTR not working properly in the beta cell, that leads to a defect in this preformed insulin secretion, and that there may also be a decrease in GLP-1 signaling as a result of this as well. So this is an example of oral glucose tolerance test and what happens to plasma insulin. When you look at the dashed line, this is what happens to insulin secretion in a patient who does not have cystic fibrosis, such as a controlled patient. And you see that after a glucose load, within 30 minutes, we reach peak glucose, and that tapers within the hour, and it returns to baseline levels after that. The next line down is the red line, and it shows a patient with cystic fibrosis who has normal glucose tolerance testing and doesn't have any abnormalities as far as we know in terms of diabetes or prediabetes. And you see how these patients at 30 minutes are not able to mount this insulin response. They lack this first phase insulin response. That does get more severe in terms of deficiency as we get to our patients with cystic fibrosis and impaired glucose tolerance. That's the green line below. And even more deficient insulin release in patients with cystic fibrosis related diabetes. But this is interesting to note that compared to controls, even our patients who don't have any known glucose abnormalities already have disordered insulin secretion. And this was also shown looking at insulinogenic index, where we're looking at essentially beta cell ability to secrete insulin and beta cell function. And compared to controls who don't have cystic fibrosis, even patients with pancreatic sufficiency and cystic fibrosis have decreased insulin secretion. So how do we diagnose diabetes? As you all know, oral glucose tolerance test currently is the gold standard because the A1C will almost always underestimate and underdiagnose diabetes. I just wanted to go over the definitions to refresh everybody's memory because we're going to use these terms. So for normal oral glucose tolerance test, we want to see a blood sugar of less than 100 fasting and less than 140 at 2 hours, right? Anything beyond that is going to be either abnormal or consistent with diabetes. So in terms of oral glucose tolerance testing, we've all known the potential pitfalls with it. And the interesting thing is that patients can move along the continuum between normal glucose tolerance versus results that would be more consistent with cystic fibrosis related diabetes, and that they can move along this continuum over time. And there are multiple processes that we've discussed that can affect which way the patient moves. And this is why we recommend that if someone has an abnormal oral glucose tolerance test, that it is repeated at some point when the patient is in their baseline health, usually at least 6 weeks after, because it can fluctuate over time. It is important to diagnose diabetes because we know that at least in the era before the highly effective modulator therapy, diabetes was associated with a loss of both BMI and lung function. And that was seen even 4 years before diagnosis of diabetes, before overtly diagnosing diabetes. We also knew, again, this is 2001, before highly effective modulator therapy, that given insulin therapy helped improve lung function and weight, BMI, in patients with cystic fibrosis. This is important because low BMI and low FEV1 or lung function are associated with increased mortality. So it was important to diagnose and treat, and there have been multiple reports and studies showing that starting insulin therapy in patients with CFRD helps reduce some of these losses in FEV1 and weight. In the past, again, before highly effective modulator therapy, diabetes and CF was also associated with increased mortality, especially in females. So it was very important, still is important, to diagnose and treat. We are going to see more complications. Now, this is 2023 was the first time that the registry was collecting data on microvascular complications of diabetes. It has been previously described in the literature that while retinopathy in patients with CFRD tends to be more rare than, for instance, in patients with type 1 diabetes, that they do tend to have more microalbuminuria or nephropathy, possibly due to some nephrotoxic antibiotics, but we will learn more about the kidney later today. Interestingly enough, even though the guidelines tell us to use insulin for cystic fibrosis-related diabetes, and that the safety and efficacy of other non-insulin medications for diabetes and CF needs to be examined on a clinical trial basis, which you will learn in the next talk. Already in 2023, up to 7% of patients with CFRD in the patient registry for Cystic Fibrosis Foundation were already reported to be treated with non-insulin therapies, so kind of off-label and using clinical judgment. So all the data I showed you about association of diabetes and CF with mortality, decreased lung function, and decreased weight was true and consistently described prior to highly effective modulator therapy. We first noticed back in 2016, there was a report in 2 cases where a CFTR potentiator for the gating mutation happened to both improve glucose tolerance as well as insulin secretion. So on the left, for case 1, you see that the left upper graph, you see the red line is patient's oral glucose tolerance testing prior to use of a potentiator, and with after the potentiator, the blue line shows that the fasting sugar, 83, was a little lower, but the patient also was below 200 at the 1 hour mark, which we don't really use for diagnostic purposes, but then they also developed reactive hypoglycemia. And we have seen this in patients who even don't have history of diabetes who were started on CFTR therapy, that sometimes they develop hypoglycemia on these drugs, especially after an oral glucose tolerance test. If you look at case 2, left lower graph, you see that after potentiator was started, patient actually no longer met criteria for diabetes on their oral glucose tolerance test because their 2 hour blood sugar was normal. So we did know that CFTR potentiation or modulator therapy could affect glycemic control, although it hasn't been widely studied prior to recently. And we also saw in our own patient cohort that sugars and A1Cs in general became lower in patients taking Trikafta without diabetes. In our cohort of 40 plus patients at WashU Adult CF Center, we did not see significant changes in A1C in patients who already had diabetes, although they did require at least temporary insulin adjustments. We saw from prior studies that patients on ivacaftor ended up gaining weight while in clinical trials for this drug back in 2016, both kids and adults. So it was reasonable to suspect that in the era of highly effective modulator therapy, we would see more overnutrition. This is our cohort from our paper in 2022, where we showed here, you see the distribution of nutritional categories in patients prior to taking Trikafta, where we had 66% patients with normal BMI, what would be considered normal BMI, and then 19.5% overweight and 6.8% obese. When we switch over to a year after Trikafta, we see significantly less patients who are undernourished, significantly less patients who are kind of considered normal BMI, which I know BMI is not a perfect indicator. I know Juliana's here, so I have to say that, but it is how we are easily able to follow, and she's right, but this is how we're easily able to extract data, so that's the caveat there. But we did significantly have more patients who now met criteria for overweight or obese category just in 1 year after starting Trikafta. And this trend also has been noted in the registry data up through 2023, where we see that, for instance, in adults, we have doubling of the overweight category and tripling the incidence of obesity. So I wanted to kind of put this together with a clinical vignette. We have a patient in our clinic who is 32 years old, who does have 1 delta F508 mutation and has pancreatic insufficiency, has been started on ATI therapy, uncontrolled diabetes when he was initially diagnosed, scheduled to do basal bolus insulin, but doesn't really do much of that because it's just hard to follow that many injections, didn't want an insulin pump, always kind of works on the go, grabs food on the go, so not always picking the most helpful foods. He has hypertension. He did have acanthosis on his exam, central adiposity, and quite elevated BMI, and he wasn't all muscle, so this probably does reflect some degree of insulin resistance and excess adipose tissue. He did have a detectable C-peptide, although it was a little bit low. This is a marker of insulin production, and sometimes it can also be low because of glucose toxicity from uncontrolled diabetes. We did follow it up 4 years later, and it was a little higher than that, but still kind of in the lower range. We did rule him out for type 1 diabetes. So some of the thoughts that we think about someone like this who may exhibit some characteristics of type 2 diabetes is starting a sensor, figuring out if we can use insulin, what kind of dietary modifications we can make, can we increase exercise, but what is the role for non-insulin therapies? You will hear a lot more about this from Dr. Mohit in the next talk. When I think about insulin resistance, I think about somebody who is requiring more than 0.5 or more than 0.8 units of insulin per kilogram per day. You can see acanthosis on exam if they have coexisting metabolic non-alcoholic liver disease, elevated triglycerides, high blood pressure, or obstructive sleep apnea. Those are all potential reasons to consider more of a phenotype and someone's trying to grab a picture, more of a phenotype of type 2 diabetes. So type 2 diabetes is kind of this ominous octet, and we call it essentially hyperglycemia with vascular disease, where you've got insulin resistance, you've got inflammation, you've got liver putting out sugar and fats putting out sugar when they're not supposed to. And in type 2 diabetes phenotype, the highest mortality comes from cardiovascular disease and heart failure. And so even though in the past we didn't see macrovascular disease in our patients with CF, now that they're living longer and that they're going to be exhibiting more of a phenotype of type 2 diabetes and insulin resistance and metabolic syndrome, we will likely see more cardiovascular disease. And I think there's been already 6 or 7 cases reported in the literature, and we have one young gentleman with an MI in our own clinic. And in terms of pathophysiology of type 2 diabetes, as you know, there's beta cell overload that occurs due to insulin resistance, and at first normal blood sugars are maintained, but after a while the beta cells can't keep up with this increased workload, and you have beta cell failure and eventual emergence of hyperglycemia. So what I'll just for the sake of time, kind of point out the important portions of this graph. We have increased sugars with meals and fasting with diabetes, not enough insulin secretion compared to normal controls after a meal challenge, and too much glucagon secretion even when it's not needed. And so that's where the incretin effect comes in and where GLP-1s come in. So here on the left, you see what happens with insulin if somebody gets an IV blood sugar load, but if a patient who doesn't have diabetes gets an oral a sugar load, their insulin secretion is actually stimulated more. And this difference between IV sugar and oral sugar's effect on insulin secretion is known as the incretin effect, because when you take sugar by mouth, your gut then secretes GLP-1 and GIP, and this effect is diminished in patients with type 2 diabetes. And this is why GLP-1 therapy has been developed for patients with type 2 diabetes. However, as Dr. Mahit will tell you, there is also issues with incretin secretion in patients with cystic fibrosis. So incretin-based therapy will, in a glucose-dependent fashion, lower glucagon to lower sugars. It will lower sugars directly, and it will augment insulin secretion, but only in a glucose-dependent fashion. So as the sugars fall down to 90, glucagon levels will begin to come up, insulin levels will begin to come down. So this is my N of 1 to show you. I have a lot more, but I picked this one because it was very dramatic. So this is my patient before starting GLP-1 with supposedly 90 units a day, which I guarantee he didn't take, but only 34% in range and 113 kilograms in weight. And then 1 year later, we've got like a 20 kilogram weight loss, and we've got 64% in range with an A1C of 7.3, which is much better. So I have a table for you that summarizes some of the similarities and differences between cystic fibrosis-related diabetes and type 2 diabetes. I think we will see these intermix more in the future. And what we do need to know more in the future, and we'll hear more in our next talk, is we need to develop an algorithm how to test and differentiate between these different phenotypes, because that may alter our treatment approach and whether or not we need to use insulin as a mainstay of treatment. So we need to know if the medications we use that are non-insulin, if they still have beneficial effects on lung function, because remember, insulin was the only recommended medication for CFRD management because it was also associated with improvement in lung function and weight. Using GLP-1s and non-insulin therapy would give us the same potential benefit. And then I predict, and we need to actually look at the data, that we will see more diabetes in pancreatically sufficient patients, which would be a key that perhaps this is a type 2 diabetes phenotype. I also think that now that even children will start highly effective modulators, that they won't go on to develop pancreatic insufficiency and they won't go on to develop CFRD, but that is my own prediction. Thank you for your attention. I know this was a lot to fit in 18 and a half minutes. Sorry for running over.
I did want to
Thank
let
you.
those standing in the back know there is several.
Car seats over the front here. So feel free to come up to the front. There's, you may just turn the seats up and turn around a little bit. So want to get everybody sitting in as much as possible. So next we have Dr. Mohit to give us a GLP-1 update. And while I'm pulling the slides, I will introduce him. Okay. So Dr. Mohi is an adult endocrinologist and associate professor in the divisions of endocrinology, diabetes, and metabolism at University of Minnesota. He is actively engaged in clinical and translational research, which is focused on examining the effect of diabetes and its complications on brain metabolism, structures, and functions. Dr. Mohi's clinical and research interests also include cystic fibrosis-related diabetes, examining the pathologies on hypoglycemia in the CF, and also developing a strategy to manage CFRD in obese or overweight people with CF. So let's welcome him. Thank you.
Thank you so much for the kind introduction. Good morning, everyone. I'd like to start off by thanking our session chairs and also the members of the organizing committee for this kind invitation. So here are the learning objectives of my presentation today. I will briefly review the physiology of incretin hormones and kind of discuss some established and under investigation benefits and potential side effects of GLP-1 receptor agonist therapies. Also examine the literature about potential incretin axis dysregulation in CF and what studies been published so far regarding CFRD treatment with these therapies. And I will kind of present data from our recently completed pilot study of semaglutide in CFRD. So incretin hormones, principally GLP-1 and GIP, are gut hormones. As you have heard in the first talk, they are secreted in response to ingestion of meal by cells in the small intestine, and they stimulate beta cells to make insulin from the pancreas. However, these hormones have a relatively short half-life, and they are inactivated pretty rapidly by an enzyme called DPP-4 inhibitor. So there are two classes of pharmacological therapies, in incretin-based pharmacological therapies. One is called DPP-4 inhibitors, and these medications inhibit this enzyme. So they work by enhancing the endogenous GLP-1 and GIP and potentiate their effect. And the second class of incretin-based therapies are synthetic analogs of GLP-1 and GIP, which are administered and they work directly on the receptors. And the GLP-1 based analog receptor based therapies they are much more potent compared to the DPP-4 inhibitor therapy. I'll focus primarily on GLP-1 today. So GLP-1 has many physiological functions. This slide really highlights their functions related to glucose regulation. As you've heard by Dr. Littman, it stimulates insulin in a glucose-dependent manner. So given by themselves, they have low risk of hypoglycemia. They also decrease postprandial glucagon, and they delay gastric emptying. So they're slowing the entry of nutrients from into the small intestine, which also helps controlling postprandial hyperglycemia. And they promote satiety and decrease appetite, centrally working on the brain. And one of the mechanisms it helps with weight loss. However, GLP-1 and GIP both are they are expressed widely. And this figure sort of gives you an idea that, they're expressed in the cardiovascular system, they're expressed in the immune system, they're expressed in the gut, in the brain. And so therefore, its metabolic actions are widespread, and they are being developed for more and more indications, as shown in this slide. And in the slide on the left, you'll see more established indication of GLP-1 based therapies. The indications listed here have shown beneficial evidence in phase 3 clinical trials, including in obesity, type 2 diabetes, obstructive sleep apnea, cardiovascular disease, metabolic liver disease, diabetic kidney disease, even osteoarthritis. And on the right, in the red, are indications for which there are ongoing clinical trials, including a potential role in neurodegenerative disorders, including substance abuse, peripheral artery disease, chronic kidney disease, hypertension, and also inflammatory disorders like psoriatic arthritis. Now, I think discussing the potential side effects of these therapies are very important, particularly in the context of CF, because CF has pre-existing comorbidities which are overlaps with some of these symptoms. So in this figure by a reviewer by Dr. Drucker, the side effects shown in the background gray are well-established side effects of incretin-based therapies, including the most common nausea, vomiting, constipation, and vomiting. These occur in about 40 to 60% of patients. However, they are typically related to initiation and dose escalation, and for most patients, they are self-limited. And then it also reduces bowel motility, increased risk of ileus, reduces gastric emptying, as we discussed, increasing gallbladder disease. So all of these are quite relevant for people with CF. With the side effects at the light blue background, these are where these are possible side effects, including worsening of neuropsychiatric events, for example, worsening of depression, concerns about suicidal ideation, and also sarcopenia, which is also a very, it could be very important for people with CF. And then the side effect listed with a question mark are where there's inconclusive evidence that they are truly caused by GLP-1, increasing risk of pancreatitis or pancreatic cancer or worsening of retinopathy. As Dr. Littman was showing earlier on in her slides, that the earliest defect in insulin defect seen in CF is the loss of the first phase of insulin response with postprandial hyperglycemia, which suggests that there is potential dysregulation of incretin hormone axis in CF. There have been studied, overall there are limited studies, but there have been studies that have looked at potential dysregulation of incretin system in CF. And I don't have the time to review all those studies, but I will highlight the main findings of some of these studies. Several studies have shown that people with CFRD have lower levels of GIP and GLP-1 compared to those without diabetes. When people with CF and pancreatic insufficiency are given pancreatic enzyme replacement, it does improve the GLP-1 GIP responses to nutrient ingestion. However, it does not normalize postprandial insulin secretion and glucose intolerance. In one study actually showed that the incretin effect, that bump that you get, as shown by Dr. Littman, by taking glucose orally, was lost in people with CFRD despite having adequate secretion of incretin, which is similar to something that's seen in type 2 diabetes. And a very recent study showed that the CFRD is associated with the reduced islet protein expression of GLP-1 receptor, which potentially could explain the previous finding. This is a study done by Dr. Andy Kelly and Dr. Rickles. In this study, adults with pancreatic insufficiency and abnormal glucose tolerance, they were randomized to receive either GLP-1 or GIP and placebo during glucose potentiate arginine testing in a double-blind crossover fashion. And what they found was that in this population, GLP-1 augmented the second phase of insulin secretion, but not the acute response to insulin to the arginine testing. Whereas the GIP did not enhance second phase or the acute insulin secretion. This is another study by Dr. Kelly's group. Here they looked at the impact of sitagliptin on endogenous GLP secretion and as well as glycemic outcome. This was a 6-month randomized double-blind placebo-controlled study. Sitagliptin is the form of DPP-4 inhibitor. The study included 26 adults with abnormal glucose tolerance and pancreatic insufficiency, and they're treated for 6 months. And you can see, as you see on the graph on the left, that when DPP-4 was given, it leads to increase in the intact GLP-1 level, as you would expect. And you don't see that increase in the placebo group. These are the results. They examined the insulin secretion during a mixed meal tolerance test. And in the bottom, you can see, bottom left, that there was some improvement in acute insulin secretion, but overall, there was no change in the glucose dynamics with 6 months of sitagliptin treatment in this group of people. This is another study of clinical use of using DPP-4 inhibitor. This is from Manchester, UK CF Center. Again, a single center retrospective analysis. Most of these people were on sitagliptin as well, although I think 1 or 2 were on linagliptin. And most of them had DPP-4 inhibitor prescribed as a monotherapy. And as you can see in this table, they looked at CGM outcomes at baseline and 3 months after using the DPP-4 inhibitor, and they showed that the glycemic outcomes improved in a number of CGM-based outcomes, including time in range, which improved from 78 to 89% time in range. This is another short-term study of sitagliptin, a DPP-4 inhibitor, on CGM outcomes. These are 17 adults with pancreatic insufficiency and had newly diagnosed or early CFRD. It was a very short-term study, just 1 week of sitagliptin treatment, and they looked at CGM before and after. And they showed that, as you can see in the graph on the right, the number of hyperglycemic peaks improved, and if you look at the CGM, the average glucose improved, and time in range also improved with sitagliptin. So far the data shows that in sitagliptin, particularly in early CFRD, seems to be safe, well tolerated, and does improve glycemic outcomes. Now, moving on to GLP-1 receptor analog therapies. Now, the data that we have on GLP-1 receptor agonist therapy are primarily just based on case report and case series so far. And I'll kind of just highlight a couple of case series of use of GLP-1 receptor analog therapies. This first case series is from our center in Minnesota. We had in this case series, we had included 5 adults who were treated for at least 2 years with GLP-1 therapy. You can see that 4 out of 5 individuals, as shown in the graph on the top, had significant weight loss ranging from 7 to 19% over 2 years. All these patients had FEV1 that remained stable or improved during this time. Insulin requirement were overall. All these participants were on insulin, so GLP-1 was used as an add-on therapy in individuals who had obese. You can see that the BMI ranged between 32 to 57. And overall, GLP-1 is pretty well tolerated. Only one individual stopped the medication after 2 years primarily because of reduction of his appetite. The outcome on glycemia was variable, as you can see in the graph at the bottom. One subject had worsening of A1C, and that worsening was particularly related to not using insulin consistently once they went on GLP-1 analog therapy. This is another case series. This is from the UT Southwestern CF Center. They have included 11 subjects with CF. They had 3 people who were pancreatic sufficient. So in the previous case series, everybody was pancreatic insufficient. Here, there were 3 pancreatic sufficient patients, and they were treated. Again, it's also included a few patients who were on the combined GIP-GLP-1 receptor analog. They were treated for a variable amount of period, anywhere from 1 month to 50 months. About half of them, on average, were treated for more than a year. And most experienced weight loss, all experienced weight loss with the median weight loss of 7 kgs. Most experienced improvement in lung function, CGM time in range improved, as well as reduced insulin requirement. And 2 individuals discontinued GLP therapy due to severe nausea and vomiting. So I'm going to move on to sort of present the results from one of the pilot studies that we have recently completed. This study has also been presented as a poster, which I've listed here. So this was a pilot study. So our main aim was really to collect feasibility and safety data of using weekly semaglutide therapy in overweight and obese patients with CFRD in hope to support a future larger randomized controlled trial. However, we did collect preliminary data to look at clinical outcomes, including insulin secretion, glucagon, and glucose as measured during OGTT, and had glycemic outcomes as CGM as A1C as well. This is the study design. It was an open-label, single-arm study for 3 months of total treatment. Semaglutide was started at the lowest dose and titrated as per usual recommendation, and we went up to 1 milligrams and continued at that till the end of the study. They had frequently sampled OGTT at the beginning and at the end of the study. They had CGM monitoring for 10 days at baseline and towards the end of the study. In this study, by protocol, patients who were on insulin had 20% reduction of insulin dose as at the baseline. So everybody got insulin. This was required by the regulatory, even people who were not well controlled, but we had reduced insulin on everyone at the beginning to reduce risk of hypoglycemia. And we really wanted for side effects very carefully and used a number of validated questionnaires looking at GI outcomes. Here are the inclusion and exclusion criteria. I won't go into all of them, but essentially they were adults, 18 years or older, all were pancreatic insufficient, and had BMI of 26 or more. These are the results. So we had 8 participants, mean age 40, 4 female, mean BMI was 29. All participants were on ETI. 5 of the 8 participants were on insulin therapy, and all the results that are shown are from changes from baseline to post-treatment at 12 weeks. And all subjects completed the study. You can see these are the results for the weight. So we had, even within 3 months, we had significant weight loss of 4.6 kg on average, and the BMI reduced as well significantly. And you can see the individual weight changes in the graph on the right. These are the results of the OGTT. They're kind of a busy slide, so I'll kind of just highlight some of the findings. As you can, the graph, you can see that there is overall improvement in the glucose curve after the ETI treatment, and there's significant improvement in area under the curve with glucose. You can see there's improvement in insulin and C-peptide levels. We didn't see changes in early insulin secretion, but the significant increase was in the later insulin secretion. And we also had, as you would expect, the lower level of glucagon in GLP-1 therapy, but they were not statistically significant. These are some other results. As you would expect, the GLP-1 levels were higher while they are on therapy. The A1C slightly improved, but there was not statistically significant. Interesting, there was AST and ALT levels were lower. I mean, these patients at baseline had normal LFTs. The lipase levels did not change. Not surprising, these were pancreatic insufficient patients, so they had low lipase level, and that did not change with semaglutide therapy. And the 2 GI-based questionnaires, which were obviously very important outcomes, we did not see any significant worsening in GI-related symptoms in this population. These are data from the CGM outcomes. Again, there was a small sample size, so we did not, we saw trends in improvement on several CGM-based outcomes. As you can see, the CGM time in range improved from 80 to 87%, but it was not statistically significant. If you look at the individual time in range, people who were poorly controlled had the most increase in time in range, and several of them had very good control at baseline, more than 90% in a couple of people. These are side effects. We kind of monitor side effects very closely. There was no adverse side effects throughout the trial. 7 out of 8 participants experienced mild to moderate adverse effects, which were primarily gastrointestinal and transient, as nausea, vomiting, and constipation. All side effects resolved without requiring dose reduction or discontinuation. And this is all the side effects that happened during the study are listed here. So in conclusion, after 12 weeks of semaglutide therapy, participants experienced significant reduction in weight, peak glucose level, and glucose area under the curve. There was increases observed in peak insulin, peak C-peptide, and GLP-1 levels. There were trends towards increases in insulin and C-peptide area under the curve, lower fasting glucose and A1C, and increased CGM time in range. Insulin doses were lower at 12 weeks compared to baseline in all participants on insulin therapy, and overall semaglutide was well tolerated. So I'll just this is my last summary slide. So again, as you've seen, there is, even though the clinical use of these therapies are increasing, but there's overall limited clinical trial data of use of incretin-based therapy in CFRD. The DPP-4 inhibitor therapy seems to be very safe. However, it has very modest, a very modest clinical response as well. But it can be used as a weight-neutral treatment option for particularly people with early CFRD with low risk of hypoglycemia. GLP-1 based therapies may be considered in individuals with CFRD who have features with metabolic syndrome, particularly when the weight loss is beneficial or if cardiorenal risk is increased. And obviously, there's more research is needed to examine the role of these GLP-1 therapies in CFRD and obesity in CF. Here are my acknowledgements, and thank you so much for your attention.
Okay, thank you. I'm going to turn a little bit now to Jessica, and let's see, here we go. So we're gonna acknowledge Lindsay Papas. She had presented these slides. Unfortunately, due to the family issues, she is unable to be here. She is a registered dietitian with the University of California, Los Angeles, Cystic Fibrosis Adult and Pediatric Care Center. So before she joined the UCLA in 2022, she worked primarily in academic and research setting at the University of North Florida and the University of Alabama in Birmingham. So Lindsay, she previously served as an NIH T32 pre-doctoral fellow and is pursuing her PhD in nutrition science focused on nutrition for individuals with CF and post-modulator era. So while we are thankful for Jessica able to step up today to present her topic and her slides, Jessica Anders, she is a registered dietitian for CF at Southern Nevada. She has over 20 years experience specializing in medical nutrition therapy. She currently serves as the primary dietitian for both the pediatric and adult clinics. Jessica also presented at national conferences and co-authored of publications. She serves as the local coordinator for the CF Social Worker and Dietitians Consortiums last spring in Las Vegas, demonstrating her commitment to advance multidisciplinary CF care. So let's welcome Jessica.
Thank you, Audrey. I just wanted to acknowledge Audrey and all of her work in helping keeping all of us organized. She was really crucial in this, getting this talk together, and to all of our speakers for being here, and to Lindsay for preparing this presentation. Unfortunately, it was pretty last minute that she was unable to make it, so I will be presenting her slides. If you think the presentation was great, come see me afterwards. If you don't like it, I'll give you Lindsay's email. All right. So I'm going to be talking about emerging evidence in cardiovascular disease risk and CF, and kind of more the diet side of things, the nutrition side of things, and where we're going from there. So I've got a little background, and then we'll be kind of getting into the more details of, as dietitians, specifically what we need to be focusing on. Some of the just general risk factors for cardiovascular disease, just a reminder here: family history of early heart disease, high cholesterol, in particular LDL and non-HDL levels, metabolic syndrome, chronic kidney disease, chronic inflammatory disease, and in general aging. So and forgive me, I do have little note cards because, like I said, I came to this a little last minute, so if I'm reading, that's why. But when we're looking at some of these risk factors, traditionally, in people without CF, you're going to see a lot of similar factors, but there's going to be some that stand out for people with CF. So in particular, chronic inflammation, oxidative stress, some of our dietary recommendations, things like that, and CF diabetes, as was discussed in the past two presentations. Looking at obesity in particular, and when you look at the graph here, what's interesting is pre-modulator, you still could see an increase in obesity, both in people without CF in our general population, but also in people with CF. Even though it's a lower amount, we still have been seeing a trend there. And now, post-CFT modulator, we're starting to see more weight gain with improved nutrient utilization, decreased metabolic demands, and then some of our necessary kind of CF legacy diet, the high-fat, high-calorie intake, switching gears from that is a little bit of a challenge, and so that's some of what I'm going to talk about here in a minute. I think everybody in the room is pretty familiar with the CF legacy diet, high fat, high salt. When we look at this diet in particular, as high as 29 to 39% of the diet is coming from fat, and in particular, a lot of times saturated fat. And so I think the key thing to pay attention to here is that while this was necessary, I think it's hard to eat a really high fat diet and also a really high fiber diet at the same time. And so a lot of times we're lacking in fiber, and that has been shown in studies where people with CF, general controls are not getting enough fiber, and people with CF are getting even less. And so another risk for cardiovascular disease, not only the high fat diet, but also the low fiber intake. As we've seen a little bit in the previous talks, effects of the CFTR modulators on cardiovascular disease risk, there's some protective factors there, looking at decreased inflammation, decreased oxidative stress, some of these things happening. That's a positive, but also we're having increased body fat content and some other risks that could actually increase some of our cardiovascular risk disease, including just aging, which is a good thing, but we have to think about these things now that we had previously really didn't have to concentrate on. So as dietitians in particular, since that's the majority of the people in this room, but even our physicians and other providers can kind of chime in with this too, what can we do? And I think a lot of it boils down to shifting our dietary focus. So we still want to focus on maintaining a healthy weight. There's no denying that that is beneficial in CF. So it's not that we're completely changing what we recommend, but how we go about it is probably going to be a little bit different in the post-modulator era. And I think in particular too, because we do have patients that cannot go on modulators, individualized nutrition therapy is more key than ever. And that's where, the expertise of dietitians in particular is necessary. It's not the same thing for every patient. Not that it ever was, but I think there was a lot more similarities, and now we have a lot more differences and different things that we're going to have to focus on. And so prevention-wise, looking at variety of fruits and vegetables, more whole grains, limited added sugars, incorporating healthier fat sources, so some of our unsaturated fats versus just focusing on fat. Okay, let's think about the type of fat, so quality versus just quantity. And then again, going back to that fiber. One thing I really like to myself personally in clinic is focus more on not so much what we can't have or what you need to limit, but more what do we need more of? So that's naturally going to replace other things. So if we can focus on, okay, we need more of this, we need to do more of that, it's going to replace the other things, and we end up with the same result. We know the benefits of fiber in decreasing cardiovascular disease, including other nutritional benefits, given the GI system within CF and a lot of things that go on that, I don't think we fully understand still to date. I think, increasing fiber, there's benefits to that besides just the cardiovascular risk. And I think we can focus on that. And that's where, as dietitians, we can kind of come in and here's your benefits, here's the things that you can see that are going to help you feel better. And a lot of times that's what people want to hear is what changes can I make to feel better on a day-to-day basis? Anytime we're changing diets, we're changing preconceived notions of diets, there's going to be barriers, there's going to be pushback, things like that from patients. I know some of the patients that I see personally that have started on modulators and have had weight gain, it's a challenge because their whole lives they've been told, eat, and as children, they were told, even if you feel full, keep eating. And now we're telling them, okay, reel it back. So, that can be difficult. And I think a good thing to keep in mind too is that kind of that switch to more whole foods, more high fiber foods, limiting processed foods. the same barriers that are in the general population are going to be in the CF population. So access and cost can become issues, preferences and habits, knowledge gaps, time constraints, social, cultural norms, and also sensory appeal. And so this is where I think as dietitians, we can really shine, provide education, work with your team, work with your social worker to find resources for people that don't have access and things like that. And so there's a lot of opportunities for discovery in this area. I think we're in a really neat time of change. And I think there's a lot of opportunities for us to make adjustments in the CF diet, change the way we're looking at things as far as screening. Are we looking at high cholesterol? I think pretty much everybody's doing that now, but that wasn't traditionally something that everybody was looking at. Medication management of blood pressure, cholesterol, diabetes is changing. We just saw that in the last two talks. And then just looking at the natural history of cardiovascular disease with an aging CF population. So all that being said, the high fat, high calorie diet that, we consider the CF legacy diet, it served a fundamental role in the care of people with CF. And so I don't want this talk to, say that we're doing anything wrong, but things are changing. And so that's where we have to change as well. We have to develop a more nuanced dietary strategy for managing patients with CF and decreasing their cardiovascular risk. And then optimizing diet is still key. It's just how we go about it is shifting. So that includes dietary guidance with the use of the GLP-1s as well. And that's all I got for you.
Thank you, Jessica, for stepping up and then presenting that slides. Then we'll keep it moving and we'll introduce. There we go. Okay. Next, Dr. Urban. She is a physician scientist who dedicated her clinical and research career to improving the care of children and young adults with a severe chronic disease. She was promoted to the tenured professor of pediatrics at the University of Virginia, where she has served as a division chief of pediatric nephrology since July 2020. Her research has been continuously funded by resources including the National Institutes of Health, Cystic Fibrosis Foundations, American Heart Association, and the Nephrocure Kidney International. Dr. Urban is a recipient of the prestigious Harry Swishman Clinical Investigator Award for the CF Foundations, awarded to these most promising clinically trained physicians to develop the biomedical research investigator actively involved in CF-related area. So please welcome Dr. Urban for a presentation titled Hypertension.
Thank you for the kind introduction and for the opportunity to actually talk to you about hypertension. And I am sure that hypertension is not a frequently discussed topic at the CF Foundation or meetings related to treatment or any issues with cystic fibrosis, because historically there was no hypertension. So throughout my talk, I'm going to actually start by orienting you what is hypertension, just giving you some basics, and then we'll just have better context for patients with CF. So blood pressure is the result of cardiac output and peripheral vascular resistance. And we can think about cardiac output as the result of blood volume, the heart contractility, peripheral vascular resistance is more of the local locally regulated by pH, by hypoxia, and by humoral factors such as angiotensin II. So these two elements, the cardiac output and the total peripheral resistance, is actually regulated by a very large number of other factors that are sort of crossing the boundaries of different organs. But this is just to exemplify how complex the blood pressure regulation is, that when one or many of these factors become dysregulated, that we have hypertension. And we can think about hypertension in one or more of the three elements here. So increased blood volume, sustained vasoconstriction, or increased vascular resistance will lead to increased blood pressure. And as the blood pressure increases in most patients who have chronic hypertension, there are no symptoms. So it's only very acute blood pressure elevation that leads to for example, headaches or other symptoms, but in sort of the slow progressing chronic hypertension, we usually don't see symptoms. So that is actually really bad situation for providers, because we frequently miss, if we don't look specifically, if we don't measure blood pressure, we miss hypertension, and the same goes with patients. They don't realize that they have hypertension. So that is one of the reasons why hypertension is really a silent killer. Just to put things in global perspective, the world prevalence of hypertension is 1.4 billion, or 33% of the global adult population. So it is staggering. It is the cause of major disability with atherosclerosis, vascular injury, and the organ damage that is happening in the heart, eye, and the kidney. Also, we don't frequently think about dementia as being the result of severe hypertension, but it is the multi-infarct dementia that is probably one of the most common causes of dementia. The mortality is 10.8 million of avoidable deaths per year, resulting primarily from stroke, heart attack, heart failure, and kidney failure. So blood pressure and hypertension is the interplay between the genetic and environmental factors. And it is thought that genetics makes up to 60% of individuals' risk for hypertension. There were studies done, these are called the Framingham Offspring Study, indicating that children of parents who had hypertension or grandparents who had hypertension are at increased risk for developing hypertension throughout life. There is also increased correlation between blood pressure and the monozygotic twins versus the dizygotic twins. So that makes the majority of the familial or genetic origin. There is also a several number of genes that can be dysregulated and lead to the monogenic forms of hypertension, but those are rare. And then the environment, that plays actually a huge role in developing hypertension. And there are four major factors. And I tend to think about these four as stress, which is sustained and excessive, inappropriate diet, so both high trans fat, salt, fructose, but at the same time also protein malnutrition, and I'll talk a little more about that, the sedentary life, and the obesity. So the interplay between what we have as sort of the genetic predisposition and what we inherited from our parents and grandparents on top of the environmental factors will eventually lead to the risk of high blood pressure and hypertension. I want to spend a little time discussing salt-sensitive hypertension, which is well recognized in the general population, but we're still learning about the mechanisms of salt-sensitive hypertension, why only some people are affected by high salt intake. So the old theory was primarily focused on the kidney, where the explanation for why blood pressure increases after sodium load was explained by the fact that people who have decreased number of nephrons for a variety of reasons, for example, prematurity, chronic kidney disease, exposure to malnutrition, so that will be inherited from the mother, and variety of other factors, including also some genetic dysregulations. So that was considered as the main reason for salt-sensitive hypertension, but it was not really giving us enough sort of the variability and granular information. So the newer theory is primarily focused on vasoconstriction. So instead of just focusing on single organ such as kidney, which obviously is very important in blood pressure regulation, it extends to sort of the inter-organ communication and the vasculature, explaining that endothelial dysfunction in different vascular beds increases blood pressure, and there is inability to relax after a sodium load, which increases water retention. There is an inability to for the blood vessels to relax and open up and decrease blood pressure. So the blood pressure increases at this time. So this is actually a very nice description and summary of the newer theories indicating, for example, the role of inflammation, the role of the gut in the endothelial dysfunction. So a lot of new data which are not focused on the mechanistic aspects, but also the interplay between sodium and how it affects the immune system and, for example, the lymphatics or the skin interstitium. So I want to actually emphasize three factors here, which are really, I think, very important and will play a role if they don't already play a role in people with CF. So the role of epigenetics in modifications of the cell-sensitive hypertension. When you look at the left side at the role of the fetus and the maternal malnutrition, as well as the maternal exposure to lipopolysaccharides or LPS. So exposure to infection, specifically the LPS, that induces modifications specifically in the genes like RAC and the angiotensin II type 1 receptor, and through the alterations in the mineralocorticoid receptor or the renal sympathetic nervous system, it impairs renal sodium handling and leads to cell-sensitive hypertension. I think we can relate this to patients with cystic fibrosis. On the other hand, in the aging population, there is also an epigenetic modification. And one of the examples here I think is fascinating. It's CLOTA. This is the anti-aging factor, which also plays a role in calcium metabolism, but decrease in CLOTA through epigenetic modifications will reduce renal blood flow and also impair renal sodium handling. So this is the more updated view on the mechanisms of cell-sensitive hypertension, and I think the epigenetics are the factors that we differ. Each of us has a little different epigenetic milieu based on not only our genes, but now the environment playing more role. And this is also very important, the gut-kidney axis. And I can second what was discussed already earlier. When you look actually on the right side, the appropriate diet, high-fiber diet, protects the gut from having dysregulated microbiome and protects from inflammation and regulates blood pressure in the normal direction. However, on the high salt diet, there is a change in the microbiome and induction of pro-inflammatory state, which increases blood pressure. So again, really great interplay between the immune system and salt. So one additional aspect that I think is more and more frequently discussed nowadays is the role of high fructose in the diet. And we are probably all a little guilty about maybe eating a little too much sugar. But those who have salt-sensitive hypertension actually are especially at risk because the fructose is going to increase the absorption of sodium in the kidney. It also activates the renin-angiotensin-aldosterone system and stimulates renal sympathetic nerve. So that's how high fructose is actually paralleling the increase in salt consumption and leading to hypertension worldwide. And this is just an example of the kidney proximal tubule reabsorbing sugar together with sodium through the SGLT receptor transporters, which are the sodium glucose co-transporters. So it's easier to transport sodium in the presence of glucose. So everything that we sort of accumulate starting from our prenatal life throughout the entire life until old age, all the risk factors, and including genetics, epigenetics, environmental factors, and in addition, some other chronic kidney condition, chronic conditions, will be the result of aging as a risk for hypertension. So aging is considered a completely independent risk for hypertension. So when we think about people with CF, the increased longevity comes as a risk for hypertension. And the multifactorial and asymptomatic nature of hypertension complicates things in the way that we don't know those people who we don't screen. People are unaware of hypertension. In the global scale, more than 40% of people are unaware that they have hypertension. So that comes to 600 million people worldwide. This is truly an epidemic. And people who have hypertension, only 23% of them have blood pressure under control. And I think we probably, or I should say and my community can take some blame for it, because we don't screen enough patients, and we don't consider blood pressure in all clinics as the very important factor, for example, for vital signs. And sometimes we trivialize that blood pressure is a little elevated. Maybe that's okay. So I think that is very, very important. And when you think about blood pressure in the global scale. So historically, again, blood pressure was not an issue, or there was no high blood pressure in people with CF, and it was thought to be relating to poor nutritional status or loss of sodium from sweat, leading to decreased volume. And these data were actually nicely presented in these two publications. However, as the life expectancy increases, the new health concern for hypertension is now emerging. And we also start to understand some more nuanced relationships between the role of CFTR and other CF pathophysiology in predisposing people to CF. And I want to mention three animal model studies. So these studies dating from 2005, so before the modulators, and focusing on the role of CFTR knockout and the effects of CFTR knockout on the vascular system. So without functioning CFTR, these investigators noticed that there is a vasoconstriction, lack of relaxation, and enhanced myogenic response after vasoactive agents are used. The last paper also evaluated the role of high fructose, high salt diet, which increased blood pressure in both the knockout animals, which has not been previously associated with just lack of CFTR, but that was noted after CFTR knockout, and it was mediated through increased arterial stiffness and also increased peripheral vascular resistance. So as a validation of these animal studies, there are two really important studies demonstrating that in people with CF, there is lower cardiac output, increased systemic vascular resistance at rest, and the second study showing also arterial stiffness and left ventricular overload. So definitely changes that are consistent with the animal studies demonstrating that there is just baseline effect on absent CFTR on the vascular system. So the emerging risk factors for hypertension in people with CF are primarily related to the improved longevity. So now we can think about those risk factors as we see them in the general population. So all the genetic familiar causes, the stress of chronic illness, the inappropriate diet. So we heard about the legacy diet, so overnutrition. At the same time, also malnutrition if patients do not respond to high-efficiency modulators, and the potential for the effect in the offspring. high salt and high fructose. Obviously, high salt has to be taken here with a grain of caution because we don't have very specific recommendations yet. Also, physical inactivity, obesity, but also very importantly, chronic inflammation, which is still the feature of in patients with CF, even those who respond to high efficiency modulators, and the role of LPS exposure during pregnancy, that will be very important, and medication side effects. So as we see increased risk of, for example, chronic kidney disease in the aging population, this was already estimated way before the modulators in cohorts. So people over 55 have 19% of risk of chronic kidney disease, which is an accelerator of cardiovascular risk and hypertension. And because we don't frequently detect hypertension sufficiently, in my opinion, there is a also parallel increased risk for hypertension. So the high-efficiency modulators also may play a role, and I want to mention two studies. This is a retrospective review from a single center of 134 patients where blood pressure was evaluated after starting ETI, and the mean follow-up was 12.2 months, and there was an increase in mean blood pressure, systolic, diastolic, and also reclassification or increased classification into type 1 or type 2 hypertension, all significant. Interestingly, there was no modification by the CFRD status in those effects of ETI. This study also evaluated 237 patients on ETI and found similar effects on the blood pressure and also increased incidence of hypertension and need for more antihypertensive medications. So just very briefly, the salt homeostasis. So patients with CF do need salt. It is very important for growth and development of children. We don't have any data now to make specific recommendations for those patients who are either responding to high efficiency modulators and have normal sweat, chloride. And I think we have to be very cautious in recommending limitation of salt. And I think we need to start examining the prevalence of hypertension in this patient population. We need to start doing 24-hour ambulatory blood pressure monitoring, which is now the recommended gold standard. And in other patient populations, it is has been shown that it can detect masked hypertension. So in summary, hypertension affects 33% of the global population. It is a huge risk, and I think the CF population is probably heading that direction. Because of lack of symptoms, we don't identify hypertension until we start looking for it. So we have CF patients really getting into the group of high risk for disability and mortality. And I would like to end by just proposing the 3 Ps: to predict, prevent, and personalize. So predict will be to identify those patients who are at risk for hypertension. Prevent by introducing and promoting healthy diet, physical activity, and stress reduction. And then gather more information, more data and studies to be able to personalize the specific recommendations for SAD to individualize. So thank you.
Thank you. Hey, that was wonderful. Finally, we have our last speaker, Dr. Alvarez, will give us a front view of nutrition considerations for age-related disease in CF. She is an associate professor at Emory University School of Medicine, the divisions of endocrinology lipids, and metabolism. She's a registered dietitian with a master in clinical nutrition with PhD in nutrition science at the University of Alabama, Birmingham. Her research integrates many aspects of nutrition and endocrine research, including rigorous clinical trials, nutritional status assessment, body compositions, and fat distributions analysis, high-resolution metabolic analysis of dietary intake, and assessment of glucose tolerance in people with CF and other chronic disease. She has been steadily funded by CFF and NIH, currently the co-director of NIH-funded P30 Nutrition's Lifestyle and Behavior Research, core of the Georgia CF Research and Translations Core Center. The goal of her research program is to gain a deep understanding of the role of diet and nutrition on CF clinical outcomes to improve the nutrition status of care for lifelong health and quality of life. Let's welcome her.
Okay, thank you, Jess and Audrey, for the invitation to present. I'm really excited about today's talk. I have nothing to disclose related to this presentation, and really the next 18 minutes will be to review dietary recommendations, hopefully for prevention of age-related diseases with considerations for people with CF. We'll talk about micronutrients, macronutrients, and I'll really focus on, more importantly, diet patterns, which we've heard some today already. And then I'll mention some of the diseases briefly that we've talked about already, as well as others. So really, we all know we can no longer consider CF just a childhood disease. The number of people now with CF has surpassed, the number of adults now with CF has surpassed the number of children with cystic fibrosis. We've gone in 30 years, from a median life expectancy of 33 to 61 years of age. This is really, really, really exciting. But we kind of have put ourselves into this out of the frying pan and into the oven situation, where we have patients who are aging with a chronic disease, but they're in this obesogenic environment with the standard American diet, the SAD diet, physical inactivity. I don't know what's in that frying pan right now. I apologize for that lump of coal. Thank you, AI. Really, our goal is going to be to maximize longevity and quality of life in the environment that we're living in right now. So midlife is truly a critical window for modifying any age-related trajectories. And we consider midlife around 40 plus years, currently in it. And we really start to see these physiologic and metabolic changes as just increased muscle loss, increased bone resorption, shifts in fat distribution. These increases, we start to see increases in non-communicable diseases that we've heard today that are linked to overweight, diet quality, and inactivity. Really important is, however, that nutrition status now, what we do in midlife, will predict the trajectory of age-related disease and functional decline later on. So this table here, take a picture of it real quick, is just a snapshot of what happens as we age and their effects on dietary needs. So energy expenditure decreases anywhere from 5 to 25% as we get older, thereby obviously decreasing our need for calories. We really need to focus on nutrient density, muscle mass, and strength decrease, increasing the need for protein. Bone resorption increases. That increases our need for protein, vitamin D, and calcium. This fat redistribution. So things move from our peripheral areas into the abdominal area. They go into our organs and even into our muscle and our bones. This is where we really need to focus on diet quality. Low added sugars, low fructose, low trans fats, decreased alcohol. Immune competence decreases as we age, increasing the need for zinc and other micronutrients associated with immunity. We've got GI changes, decreased nutrient absorption, increasing the need for folate, B12, calcium, vitamin K. Menopause influences all of these things that I've just talked about, but also might decrease the need for iron with the loss of menstruation. As we age, we start losing our ability to convert vitamin D in the skin, as well as activation in the kidneys, increasing needs there, and then our ability to regulate fluid balance decreases, but that depends on the individual. So sometimes we might need more fluid, sometimes less. I would be remiss not to mention that for a lot of these, while my focus is on nutrition, but resistance and aerobic training are equally as important. So that's important. Okay, so these are some of the nutrition priorities for middle age. It's not an exhaustive list, but a good bit of them. So calcium, vitamin D, we mentioned some of these already. For bone health, B12 and folate, needed for methylation, for cardiometabolic and cognitive health. Magnesium and potassium for blood pressure regulation, muscle contraction of the heart and skeletal muscle. Our monounsaturated and polyunsaturated fats are anti-inflammatory, help with cardiometabolic health as well as cognitive function. Fiber is finally making a comeback. So this is, we need this for our gut bacteria, beneficial gut bacteria, production of short chain fatty acids, colonic mucosal health. So thinking about colon cancer, regulation of glycemic and lipids, sugars and lipids, as well as weight control. And then, of course, protein needs increase as we age, and I've got the recommendations there for older populations. This is to support lean mass, bone density, and weight control. Unfortunately, this is NHANES data. NHANES data has shown that depending on the age group, there are lots of micronutrients that people from 19 through 71 years of age are not meeting with. Some of almost half the population has not been meeting the adequate intakes or estimated average requirements set by the DRIs through diet only. But we do know that nutrition is a modifiable risk for age-related diseases that we've mentioned here today. And we're working on, research is ongoing on whether some of these CF-specific diseases that are related to the general population diseases can also be modifiable through nutrition. So muscle mass and strength are absolutely critical for long-term outcomes and survival. And we've got a wonderful PhD student in our lab, Lucia, who's here, has just published a paper showing that people with CF have lower appendicular skeletal muscle index, lower skeletal muscle strength. And when we looked at the prevalence of low skeletal muscle, it was actually 4 times higher in our group of controls compared to a group of CF compared to our healthy controls. And if you stick around a little bit later today, you'll see similar things in our Strong CF study presented by Dr. Melissa Putman in a multi-center study, hopefully confirming what some of the things we've already seen. We know in the general population that excess adiposity contributes to age-related disease in people without CF, especially adiposity within our visceral area surrounding our organs. This leads to insulin resistance, hyperinsulinemia, overall glucose intolerance, and promotes type 2 diabetes, cardiometabolic disease, as well as cancer. And this occurs through several different pro-inflammatory oxidative stress pathways. Our lab and others have shown that people with CF, adults with CF at least, have higher visceral adipose tissue compared to healthy controls. And in this study by then PhD student Mariah Bellissimo, higher visceral fat was shown even in people who were matched for BMI and overall body composition. We had another postdoc, Bright Supakajanusant, who presented here a few years ago that higher total fat and higher visceral adiposity was inversely associated with measures of insulin resistance from an oral glucose tolerance test. So, more shameless plugs. Stick around and you'll hear some really interesting information on body fat distribution measured through MRI on more robust outcomes related to glucose and insulin in a poster talk by Lucia. So, visceral fat is, we know this to be associated with metabolic outcomes. But we've also just published a study showing that it can actually interfere with that relationship between muscle mass and muscle function in CF. And so again, this is in that paper that Lucia just published where she dichotomized people based on a median endpoint of high versus low visceral fat. And what she found was as expected, those with a low visceral fat, there was a positive relationship between muscle mass and sit-to-stand test, so a measure of function. But in those who had higher visceral fat, that relationship was pretty null, so it sort of nullified the relationship between muscle mass and muscle function. So all of that to tell you that conditions associated with aging, low muscle, increased visceral fat, are prevalent in people with cystic fibrosis. And this is happening at an even younger age than what we would expect than the general population. So there are evidence-based nutrition strategies for the prevention of all of the aging-associated diseases we've talked about today. And you'll see a lot of repetition here. Maintaining a healthy BMI, maintaining a healthy dietary pattern. Some of those dietary patterns that are well-studied are the Mediterranean diet, DASH diet, healthy eating index, plant-based diet, and low glycemic load diet. Very, very consistent. These are all evidence-based, as I said. And I won't go through each and every single component of the diet. This is another nice snapshot. And Audrey, thank you for the suggestion to put it in something that looks like this. But you can see there's a lot of similarities between all of these diets. Increased fruits and vegetables, increased lentils, beans. Animal protein should be lean, or fish, nuts, seeds, whole grains. If you're looking at dairy, low-fat dairies, and increase intake of their beneficial fats, olive oil, omega-3 fatty acids, limited red and processed meat, limited added sugars. I've added a few diets here just to point out. So one of them is the Alternative Healthy Eating Index, which was developed at Harvard, sort of in contrast to the Healthy Eating Index was based on whether you followed federal guidelines for nutrition, depending on which year you're doing it. The Alternative Healthy Index was developed based on actual risk for chronic disease. And then the MIND diet is kind of a newer-ish diet that's a blend between Mediterranean and DASH diet, meant to focus on cognitive health outcomes such as Alzheimer's. So there's a really great study that was published this year, actually. It's one of those that you wish you'd done yourself. It was out of Harvard. It looked at longitudinal outcomes, over 100,000 people from the Nurses' Health Study and the Health Professionals Follow-Up Study, and looked at long-term adherence to 8 different dietary patterns and healthy aging with up to 30 years of follow-up. Beautiful study. So what they did, they looked at the Alternative Healthy Eating Index, some of the ones we talked to today. They also looked at a Planetary Health Index, which was a diet that was developed through this Eat Lancet Commission made to optimize human health, but also health of the environment, which was really interesting. And then this EDIH is sort of diet related to hyperinsulinemia, or the opposite of hyperinsulinemia. And EDIP is more inflammation-based, so anti-inflammatory type foods. So what they found across the board was that no matter which of the diets they looked at, there was significant odds ratio of living a longer with healthy aging, no matter what the diet was. And so healthy aging for them was defined as surviving to 70 years without the presence of major chronic diseases and no impairment in cognitive function, physical function, or mental health. And so that includes cancer, MI, coronary artery disease. They're all listed here and include some of the stuff we've been talking today. So their major outcome, they loved the Alternative Healthy Eating Index, which was great. So that was what they deemed to be the healthiest diet. But really, I think the secret to healthy aging, their secret was really disclosed in the abstract, where they say higher intakes of fruits, vegetables, whole grains, unsaturated fats, nuts, legumes, low-fat dairy products were linked to greater odds of healthy aging, whereas higher intakes of trans fats, sodium, sugary beverages, and redder processed meats were inversely associated with healthy aging. That is the secret. We can stop everything now. We can include Life Simple 8 in this list. A little bit of a soapbox here is that I want to stress that cultural flexibility when we're thinking about dietary patterns is really, really key. I absolutely love the Mediterranean diet, but we have to recognize that these dietary principles, the secrets to healthy aging, are adaptable to diverse cultural food traditions and can be utilized through East Asian, African, Latin American, Native American, South Asian diets. Just a quick little soapbox. When it comes to CF, we have, us and others have studied diet quality in relation to outcomes. So this is a study published by Dr. Tanisha Daly looking at measures of diet quality, including added sugar and fasted measures of glucose tolerance, showing these healthier measures of food are associated with better outcomes. And stick around the next session and you'll hear her talk a little bit more about added sugar intake, body composition, and more than just fasted measures of glucose outcomes. Last shameless plug, I promise. On Saturday, our recent graduate, Matthias Shore, will be presenting on dietary fats and dietary fat quality in association with increased adiposity in people with CF. So we do have some guidelines. I know we've talked extensively about the legacy diet, but we do have some guidelines to help us. We still need to focus, obviously, on aging with CF, but these 2020 guidelines, developed with several people in the room, including Dr. Bailey, we emphasized a healthy diet with foods that emphasize positive health outcomes in the general population, with supplementation as needed. We emphasize dietary pattern that promotes consumption of nutrient-dense foods, including healthy fats and micronutrients. For those not at risk of malnutrition, because as Jessica mentioned, there's a huge spectrum of where our patients are on the nutrition-wise. The recommendation was looking at macronutrient fat distributions that or macronutrient distributions that are similar to the general age-matched population. And then with CF-related diabetes, at least emphasizing limiting high sugar foods and beverages with low nutrient density. So I'll end with where should we focus our energy? One, we've heard this earlier from Jessica, understand that nutrient needs for our patients are individual and working with you guys, the registered dietitians, on best way to meet unique needs. Focus on overall diet quality. Jess, I love what you said. How can I add? What do I not focus more on that? Not what do I need to take away? How do I need to be restrictive? Focus on building muscle and being active. For our families, I know this is an aging talk, but life starts now. Model healthy eating and lifestyle patterns for all. Introduce veggies and other healthier foods early and consistently. Make healthy foods accessible at home, obviously within budgetary constraints. And this is another one that I think is really important for everybody in the room, everyone in the world, is to learn to spot and unfollow social media red flags. There are a lot of influencers out there, and we just need to cancel those. So ultimate goals. This is that we're trying to create and teach healthy habits that carry into adulthood and through adulthood. That we need to implement routine screening long before these age-related diseases become prevalent. And really, we want to be able to refine CF-specific lifestyle interventions that support age-focused healthy behaviors. Oh, I'm so good on time. So I will just like to acknowledge my A to Z Nutrition Lab. They're sitting right here. Happy birthday, Swati. Our Emory CF Center and our wonderful external collaborators outside of Emory, funding support through the CF Foundation and the NIH, and of course our CF community and our research participants.
Thank you all. That was a wonderful wrap up. And I think that's all concluded our presentations. So I'm going to take the Q&A. If anybody wants to step out of the mic, there's one, two here, or submit it through the apps.
Hi, I'm Tara Bartow from Baylor. Thank you. Phenomenal talk. I'm blown away. I had a question about, we talked a lot about the changing face of CF and all the risk factors. Is there any outcomes data looking at older population and macrovascular changes like coronary artery disease? I mean, clearly I think there's a lot of chronic kidney disease and some things related to diabetes, but I believe there's some very old data looking at postmortem studies and how there may even be something protective in CF for like coronary artery disease. I didn't know if there was any outcome data for that.
Yes.
Yes.
Sorry. Katie Larsenodi from Pediatric Endocrinology, University of Iowa. So Freddie Frost out of the UK has a wonderful recent study, it was just a database extraction, but it was both European and US data, and they showed that severe cardiac events are common in people with CF. That's actually related to the question I wanted to ask the team. So, but yeah, so the protective effect on cardiovascular disease, as best we know, is because there's specific malabsorption for cholesterol in people with pancreatic insufficiency, and even probably more in CF than there is with other forms of fat malabsorption. So my question for you guys is that we use cholesterol patterns to decide if people have cardiovascular risk. And what we saw in those studies that everybody so nicely brought up is that we're seeing MIs in people with CF, especially those with diabetes, but the cholesterol levels, microphone turned off, probably because I talk too much. The cholesterol levels that we see in those people are still low and not at the cutoff points we would normally use in a diabetic or any other group of people to determine at risk. And so I'm wondering if you guys think we should be following maybe the delta rather than absolute cutoffs for lipids. What do you think?
Great question. I knew it was going to be puzzling when I saw you walk up to the mic. I want to back off to the prior question in terms of heart disease and CF risk. So before advent of highly effective modulators, for people who had coronary angiograms prior to lung transplant, there was virtually non-existent known coronary artery disease, but we didn't have the aging population we do now. We do know now, we have some, just anecdotally, we need to study this more systematically. There seems to be younger age, like with the patient in our institution with uncontrolled diabetes and CKD was 35 when he had major LAD occlusion. So I think we'll see this more, and it's going to be hard to tease apart what's what. Also, I think it was the same study you mentioned, Katie, where just the propensity risk or the estimation of risk of atrial fibrillation, I think it was in heart failure in patients with cystic fibrosis, is supposed to be on par with people with other chronic inflammatory disease like lupus, rheumatoid arthritis, and HIV. So it's predicted that they may be at higher risk. So I'm not sure about the discrepancy between what's been previously described on autopsy studies, and I'm not familiar with that data versus what is emerging now. To answer your question, Katie, from our adult cohort that we've seen, that we published about the Trikafta, 1 year post Trikafta, we saw that HDL remained low, which is a risk factor, I think. And then the triglycerides, which are almost universally elevated, tended to stay the same, partially due to kind of counterbalancing, this is my theory, between decreased inflammation with highly effective modulators, yet increasing weight, possibly insulin resistance, and changes in absorption and diet. So I think we shouldn't forget that triglycerides can also contribute to cardiometabolic risk. However, I think we need to know more information because a lot of my patients, their LDLs are like below 50. So I probably wouldn't necessarily want to use a statin just from that. So I don't think we know. What do you think? What do you guys think?
Trying to push it or is active? Yeah, I think from the Frost study that everybody's bringing up, I mean, majority of the cardiovascular events are not coronary artery disease, and just atrial fibrillation and others. So that's important to highlight. I think one of the things that we have been doing, and Dr. Hanzabudi, one from our group, is studying this in some we are actually doing in some patients, and it's not clinically recommended if it's covered by insurance or you're able to, we are looking at calcium scoring as well, just to risk stratify. And we have done it in few patients, and actually we found it in, a little bit high in a few and zero in others. So that has helped us risk stratify, and you can just openly talk about it, lack of evidence, and starting statin based on that. Some patients have elevated statin levels, and we are, even if we start in that, but others who have long duration diabetes, other risk factors, but statins are not high, where possible, we are doing those statins. And Dr. Hadwood is doing a study in aging population, especially in women who are around menopause or after, and we'll look at it screening, and so that data will be helpful as well.
Okay, we had some online questions. Okay, there we go. Do you think is the role of a CF team to manage cholesterol and then blood pressures, or should be this be the GP? A survey carried out locally to us showed a lack of confidence in assessing the risk of heart disease, and where the treats both cholesterol within the CF highlights our training needs to be referring out.
I think that's a really good question. I think we struggle with that as well. I think our pulmonologists are really good at identifying hypertension, particularly, and starting on antihypertension medications. But we are also looking at hopefully finding PCPs, just as we have endocrinologists or gastroenterologists, PCPs who have expertise in taking care of people with CF, and to recruit them in this area. So I think it could be depending. It's very center dependent, I guess. I think what I've seen in pulmonary is that they have so many things on their plate already. I mean, their problem list is like so long when they're seeing the patient, this adds to it. But many times patients are just much more likely to see their pulmonologist than other providers as well. So that's another challenge. But I think it's a multidisciplinary sort of approach. If they are seeing, it's not any one person. Certainly, if they are seeing endocrinologists and PCP, they can manage it as well. I think we all have to increase the knowledge base of how to treat and develop guidelines, so more people are comfortable in terms of recognizing and treating it.
Go ahead.
I just want to bring up again the ambulatory blood pressure monitoring, the 24-hour blood pressure monitoring. It is really critical. It is gold standard. With single office blood pressure, we cannot really get a good insight of what is happening in the patient, and it's most of the time the blood pressure is not even done correctly. So we don't follow the guidelines of having the patient rest for 15 minutes in a quiet room. So those data, I think, are very messy. So just starting by following the guidelines, for example, from KDOCI or American Academy of Pediatrics of yearly ambulatory blood pressure monitoring, I think it will be a huge benefit to the entire population, will sort of put us on a different path, understanding what is the prevalence of hypertension.
I think it's time for a shameless plug. So I just wanted to, Dr. Tanisha Daly is here, and so she is doing a spectrum study. Some of you may be part from centers where, and they will be doing 24-hour monitoring for blood pressure to better screen and identify hypertension. So I think it's clinically available, and I think it's an absolutely great tool to use. Yeah.
And just to add, like in our center, we our pulmonologist service PCPs for almost our entire adult cohort, but we do look at the blood pressure on intake. We do try to get them to measure at home as best as they can. But just to point out two things that we can address in this context. So one is, the salt intake in the context of highly effective modulator therapies. Our dietitian will review that to screen for excessive salt intake, and then especially with ongoing rise of overnutrition, ruling out obstructive sleep apnea when it's appropriate, because it can contribute to blood pressure increase.
Okay, I'm going to follow up this really quick. I want to jump onto the mic. Yeah, so this one was a follow-up with Dr. Mohit said, you mentioned a plan for a larger RCT of a semaglutide in the overnourished people with CF. Will your team collect the data on body compositions and or dietary intake as a part of this study, given concern of sarcopenia on GLP-1?
Well, I think absolutely. I think that's a great idea. Our study was very small and short, so we didn't really have enough time period to add body composition. But I think any future study should absolutely look at the measured dietary outcomes in a more formal way. and how these medications are affecting dietary intake and patterns and body composition. I think sarcopenia is a real concern in general, even type 2 and obese population where it's being used. There's some evidence that's evolving that even though lean body mass may be going down, but actually muscle quality strength may not be affected or even getting better. So there's some sort of conflicting data, but it's evolving with GLP-1s. But I agree. I hope we are able to do some sort of a large multi-center study where we can study all those things that you pointed out. Thank you for a that's an excellent comment.
Tom Ziegler, Emory University. That was a great symposium. Congratulations to all the speakers. Just for Dr. Swiatecka-Urban on the hypertension with the modulators, I had not been familiar with it. It seems pretty large. I mean, around 3 to 5 millimeters of mercury on each side. And so I'm glad you guys everybody's studying it. Are there any data on the use of antihypertensives in the population yet, given that these drugs have been around for 3 or 4 years?
Yeah, I just want to make sure that I understood your question. Data on the use of antihypertensive medication? Yeah. Okay.
Yeah, given that it looks like these drugs are contributing to a
Yes.
rise in blood pressure, are there any signals that folks are, as they become more adults, are using more antihypertensive medicines?
So I don't think we have the data yet. These were 2 single-center retrospective studies, and I think that just indicates that we need to have more data available. But I think probably there is access to a lot of information that can be retrieved even retrospectively to identify maybe the specific class of medication that is going to be most beneficial. I think that will be first important aspect. But my feeling also is that the medications may be affecting a CFTR function that is still unrecognized and function that from some animal studies, there were 2 papers, not very strong, but 2 papers suggesting that CFTR may actually lead to a specific mechanism in hypertension. So I think more data is really needed, but I think it's too early right now to know. But the association, like you notice, is definitely there.
I actually got a question for you. I have a question for you. Do you think that change in hypertension after ETI, was that independent of changes in body mass index, or do you think those are linked?
Yeah, so this was not studied. I'm sure the data are there. It was not in the paper. One strong point that the authors made was that there was no association or no modification with CFRD, but I'm sure they have the data, so it can be reviewed again.
There's one online follow-up with Dr. Urban. Many patients come into the clinic are stressed and have hypertension or pre-hypertension due to anxiety. In your clinic, how do you distinguish white coat hypertension from sustained hypertension?
Right, now, it's an amazing time to talk about white coat hypertension in people with CF. I think we are in the good place that the longevity is there. We have, now we can approach these patients as general population. So again, the 24-hour blood pressure monitoring, that will distinguish the white coat, the anxiety-related hypertension. Our team has a full-time psychologist who works with us. So we have a full evaluation by a psychologist. So we look at the mind and the body. I think that is really critical. But the focus on ambulatory blood pressure monitoring, I cannot just stress it enough that it will help to distinguish blood pressure, different categories. And for example, for a nephrologist, we take 3 blood pressures taken at different times within 3 months as the diagnosis of hypertension. If it has to be done by just ambulatory single office blood pressure measurements, but we always have these ABPM monitors that we send to patients later, and we are able to eliminate not only white coat or anxiety related, but we also can determine the daytime versus the nighttime blood pressure. At night, there is supposed to be a nocturnal dipping, so blood pressure needs to go down. Patients who do not have that component are at risk, independent risk of having cardiovascular complications later in life. These are just data from general population. So even in young people, I'm a pediatric nephrologist, so even in children, if we don't see nocturnal dipping, we start them on ACE inhibitors or ARBs because we know that that leads later in life to severe complications in the cardiovascular system. So I think the same studies can be done in people with CF to learn more.
Okay. One more following up with that. What do you recommend for patients with hypertension, but either no repeated sweat or sweat test is not normalized on ETI? Without this repeated sweat, patients are still seeing salt crystals when they sweat, suggesting continued increased salt loss?
Yeah, so I would not really touch the salt. I think the salt needs to be there, right? The patients need to actually, if patients have abnormal sweat test and they're still at risk for hypovolemia and for electrolyte disturbance. So that will not lead to, if they consume salt, this will not lead to hypertension. And I think hypertension is I think we should start sort of pointing away from that, blaming only salt. And as I was presenting, in addition to salt, there's also the epigenetic modification that not every patient, not every person has. So only some of us are sensitive. And so we have to look at other causes. And it is hard to really provide very specific information. I would say please involve your nephrologist because they will look more globally and address and review the patient's history and give you more specific information about the etiology and treatment.
Okay. So if patient is on GLP-1 just for weight loss, should their OGTT test still proceed and will it be valid?
That's a good question. There's not been any published study that I'm aware of using GLP-1 in without diabetes. There was an abstract presented by some of our colleagues last year, which is not published yet, but a case series showing that is effective in using the medication even without diabetes. So I think that's a good question. Just if you look at GLP-1 drugs, just like metformin, they can prevent the progression from pre-diabetes to diabetes and type 2 diabetes, for example. So it can sort of, so I think they should still be screened for diabetes, knowing that this may impact and may reduce potentially, we don't know for sure, especially if they have type 2 sort of phenotype, or if they have risk of developing type 2 on top of CFRD pathophysiology. So yeah, they should continue to be screened, and that knowing that, that may impact the results.
Okay, this is for Dr. Alvarez. Jessica, thank you so much for your wonderful talk. I'm curious about your slide regarding to the future focus on the CF diet. Can you explain a little bit more about why those 5 things were selected? I'm especially interested in why protein wasn't mentioned on it. Oh, I'm sorry.
Deny. Just general information from studies that had been looked at. I think Lindsay just pulled together kind of general information. I do agree protein should be included. I think the main focus was just on related to cardiovascular disease in particular, fiber, lower fat, things like that. Doesn't mean it's exhaustive of all changes for related to nutrition and the aging population.
Okay, thank you, Jessica, for stepping in the era of a him. Since the most patients qualify, how do you change in the conversations from an early age? Also, how are you handling and changing the conversations now in adults on him who were previously told eat everything? How do you encourage adults to change, and what, including your language and terms, that you are finding work the best?
I think I have the benefit of our adult physician also kind of addresses some of these things, and she'll kind of joke with the patient, like, now you have to eat like the rest of us, but that gives me kind of room to come in and then discuss what that means. I think, like I said in the talk, focusing more on, okay, what should we be eating and what can we add versus what do we need to limit, can be very helpful. And then also just focusing with the patients individually, what do you like to eat? What do you typically do? And then how can we work within that to help you make sure that you're maintaining a healthy weight, doing the things you need to do, but also being satisfied in your diets. And so that's where I think as dietitians, that's our specific area, because our physicians aren't going to have time to go break that down and go through, but we have the time, that's part of our expertise. And so we can really spend that time with them. And I think just meeting people where they're at too, and being honest with them that, yeah, this has changed and it's hard and it doesn't, it's not always simple to change the way you eat. And yes, I know we've been telling you this for years and years, but now we're in a different era. We have different medications and it's affecting you nutritionally. And so we have to change nutritionally what you're doing. And I also will sometimes come from a personal aspect, nothing significant, but I'll tell people, I like candy. I'm a dietitian. I like candy and I don't really like a lot of vegetables, but I know I need to eat them. And so, sometimes just making it relatable can be helpful. And then as far as children go, because I do both pediatric and adults, and having those conversations early that, yes, we look at weight because there is correlation there with lung function, but also, letting them know that things are changing in the world of nutrition and the world of CF. And so things might be changing as we go along, but also let's incorporate getting in fruits and vegetables, getting a wide variety in their diet, things like that to help them as they grow. I think anything you would say to anybody that doesn't have CF, trying to get those kids to eat different things.
I'm going to do the one last questions, and then I will request all the speakers to share our slides and through the CF lister, so that will help. So thank you so much, everyone, for the insight. Dr. Levine, for patients that are started on hemp and having OGTT but shows a hypoglycemia, such as blood sugars less than 70, and the patient doesn't have a CFRD, how would you consult these patients in terms of a diet and management? And also, what other tests would you consider ordering to evaluate if anything else is going on?
So for patients who develop hypoglycemia after an oral glucose tolerance test on highly effective modulators, is that right? So even prior to highly effective modulators, reactive hypoglycemia after an oral glucose tolerance test is quite common, especially at third hour, which we don't routinely collect that data, but it is a known phenomenon. And so the question is whether or not that phenomenon represents a risk of developing CFRD in the future. So I think when that happens, we actually try to get we get our dietitians involved anyway, but we highlight the importance of not eating just simple sugars, but making sure that anytime somebody eats or drinks something, that it's not plain sugar, that you've got your protein, you've got some fiber so that you can slow down the glucose absorption and thus the insulin response. So the key would be some dietary modifications and getting more information. We use outpatient CGM monitoring quite a bit to monitor for potential hypoglycemia or even testing your sugars after a high carb meal, or if you're not feeling well or experiencing symptoms of hypoglycemia. And usually we can change it with diet. In terms of oral glucose tolerance testing, there was a couple of years ago, Dr. Rabassa's group reported, the Canadian cohort, that if your patient doesn't have any signs of clinical deterioration in terms of unexplained weight loss or unexplained lung function decline, that an A1C cutoff of 5.5% or less can prevent you from needing to do an oral glucose tolerance test, right? Remembering that correctly. So in the future, if you have patients who meet those particular criteria, maybe you can forego an oral glucose tolerance test to limit that scenario in which somebody takes 75 grams of plain carbohydrates and then ends up getting reactive hypoglycemia.
Okay. Thank you. I know our time is up. There's still a few more questions, but we can have our speakers and try to reach it out to answer that. Thank you all. Appreciate it.